Thank you, Patrick, and maybe stay tuned so that if we can answer some of the questions in the chat, you and I, we can tackle them together. So thank you very much. I have the pleasure to introduce the next speaker of this evening. He's actually a friend and a colleague also, Dr. Andrew Trout, who will speak to us about pancreatic function assessment by imaging. Andrew is an associate professor of radiology and pediatrics at Cincinnati Children's Hospital. He is also the director of clinical research for radiology and the lead radiologist for our Pancreas Center research. He has done a lot of work in this field, including society guidelines for management and workup in terms of imaging for pancreatic disease. So Andrew, the floor is yours.
Excellent, thank you. Thanks for the invitation. Thanks for the kind introduction. I always like to come and chat with you folks about what you can do with imaging, what we're here to collaborate with on an imaging standpoint. So hopefully everybody finds this useful. And I think it's going to be a nice follow-on to Dr. Yahimsky's talk there, as he did speak about some of the things that we are able to look at with imaging and some of the characterization that we're able to make. Couple of disclosures. I do have an updated disclosure. We are beginning a collaboration with Perspectum that is looking at pancreatic duct mapping by MRI, but I'm not sure that's particularly relevant today, other than it happens to involve the same organ we're talking about. But other than that, no relevant disclosures. So by way of an outline for what we're going to go through in the next 20 minutes here or less, talk first about what we can assess or measure by imaging that can be linked with pancreatic function, both endocrine and exocrine, and then what specific imaging modalities we can use to assess function both directly and indirectly. And then we'll talk a little bit about some of the data that currently exists out there in the literature. Obviously, we don't have time to go through everything here. So starting right off the bat with what we can assess or measure by imaging, if we sort of think about some of the pancreatic characteristics that are accessible by imaging that we can potentially link back to pancreatic function, we can think in terms of parenchymal bulk, parenchymal quality, parenchymal perfusion, duct changes of generally chronic pancreatitis, and then secretory response. And if we look at the various modalities that we typically use when we're imaging the pancreas, ultrasound, CT, and MRI are the big ones that I'm talking about. Non-invasive modalities, obviously EUS and ERCP have roles as well, but I'm a radiologist, and so that's outside of my area of expertise. But as it relates to the non-invasive imaging modalities, each of these does play some role in measuring some of these things or assessing some of these things, but not all of them. So when we think about parenchymal bulk, all three modalities can be used to assess parenchymal bulk in different ways. Parenchymal quality, in other words, how good is the pancreatic parenchyma regardless of bulk, is probably best assessed by MRI, given the different sequences we have available to us. Not yet clear whether we can get very far with transabdominal ultrasound and know that there's data out there regarding Rosemont criteria for endoscopic ultrasound. CT, not a huge body of literature in that space as well. So mostly MRI in the parenchymal quality section. When we think about parenchymal perfusion as a marker of pancreatic function, we can look at that with MRI without contrast material. But we can also look at it with CT and ultrasound with contrast material, with the caveat being that perfusion imaging with CT is a relatively high dose exam, so it's not really in favor per se. Duct changes pretty much only assessed reasonably well by MRI. And then as it relates to secretory response, all that's out there in the literature at this point is using MRI and ultrasound to assess this. So what are these various different things that we can assess or characteristics we can assess by imaging? What have they been linked to in terms of pancreatic function? So as was mentioned, parenchymal bulk, in other words, how much mass of pancreas you have, has been linked to both endocrine and to exocrine function. Parenchymal quality, which we'll talk about in more detail, in other words, how good is the parenchyma that you have, has been linked to exocrine function. Parenchymal perfusion to exocrine function as well. Duct changes, other than frank obstruction of the duct, it was mentioned in the prior talk, hasn't really been linked to parenchymal function in any significant degree. And then secretory response has also been linked to exocrine function. So if we think about these different characteristics and what they allow us to assess with the pancreas, when we're looking for direct assessment, in other words, a direct link between what we're seeing on imaging and function, really the only one of these measures that gets to that is secretory response, and that's getting at exocrine function. The other modalities that we, or the other qualities that we can measure of the various different organs really are sort of a two-step dance in the sense that you can assess parenchymal bulk, and then that in turn has been linked back to, say, exocrine or endocrine function, but it's a two-step conversion there, as opposed to with the secretory response, where you can truly just measure the amount of fluid that is produced by the pancreas. And we don't yet have any direct imaging modality that allows us to measure beta cell or beta cell mass or beta cell function. And so we can't yet directly measure endocrine function by imaging. So it is still an extrapolation. So talking about secretory response as a measure of pancreatic function, response to secretin has been linked to exocrine insufficiency, particularly insufficiency related to low bicarbonate. It's important to recognize that what we're measuring by imaging is the volume of fluid that is secreted, not the content of the fluid and not the enzymatic activity within the fluid. So it is a bit different than what is measured by direct pancreatic function testing with fluid sampling by endoscopy or other methods. It's important to know that when you're doing this by imaging, you do need to use secretin and not CCK. The problem with using CCK, of course, is it causes the gallbladder to contract. So when you're measuring fluid volume, you can't separate bile from pancreatic juice. One important thing to recognize is that the landscape around secretin has changed a little bit. There used to be a few sort of relative contraindications. At this point, according to the package insert, the only contraindication to use of secretin is allergy to secretin. Other relative contraindications have been removed from the package insert. So what can we measure by using secretin? Well, secretin stimulates bicarbonate secretion from duct cells, as you know, resulting in fluid secretion into the bowel. And we can assess this in either semi-quantitative or more truly quantitative measures. And so shown on the right here are color-coded diagrams for what are the Matos criteria, which is a semi-quantitative assessment of secretory function. So grade 0, no fluid secretion; grade 1, filling only the duodenal bulb; grade 2, to the level of the genu inferius, or the junction of the second and third portions of the duodenum; and grade 3, fluid secretion that fills the duodenum well beyond the genu inferius, and at least as we see in children, spills over into the jejunum. And so the only degree of fluid secretion that's considered normal is grade 3, which is colored in blue there. Anything less than filling to the junction of the second and third portion of the duodenum filling beyond the second and third portion of the duodenum is considered abnormal. So grade 0, grade 1, grade 2 considered abnormal, semi-quantitatively abnormal according to the Matos criteria. Now we can get a bit more quantitative about this. Here are MRI images from a patient pre and post secretin. These are just single slab images, and then these are maximum intensity projection images at the bottom here, where we've essentially summed the images over the entire imaging stack. And what you can see is prior to secretin administration, there's a little bit of fluid in the bowel. And then following secretin administration, we see the duodenum fill out nicely, and we see accumulation of quite a bit more fluid over in the jejunum as that fluid has rounded its way over and spilled into the jejunum. So semi-quantitatively, according to Matos criteria here, this is a normal response, filling beyond the junction of the genu inferius and crossing over to the left side of the abdomen. Using image segmentation techniques where we can highlight pixels and count fluid pixels, we can get to true quantitation of the volume of fluid that is secreted. So we measure the fluid volume prior to secretin administration and then do the same measurement post-secretin administration, and by subtracting, we can figure out the fluid volume that was secreted. And we have some data that we have published regarding normative values in the pediatric population. There are some adult data out there as well. In terms of what we expect for normal secretory function, or at least the 5th percentile, so the low threshold of what we would consider to be normal, 43 milliliters volume on average across the pediatric population, or a regression equation here at the bottom based on body surface area, with expecting increases in fluid secretion as children get larger and grow into adulthood. Secretory response can also be assessed by ultrasound, but instead of being volumetric, like I just described to you by MRI, where we're measuring the volume of fluid, ultrasound instead looks at a cross-sectional area. So here on the top image, a transaxial image showing the pancreas here denoted by the P. The duodenum is collapsed. They give secretin and the duodenum fills up with fluid. And what they did in this study was to measure the cross-sectional area of the distended section of the duodenum. So really, you're only getting one piece of the duodenum that you're actually capturing here. So if there's significant fluid reflux into the stomach, which we know occurs, or significant downstream flow, it may not quite fully represent the secreted fluid that you're actually seeing. That said, there is some evidence to suggest that there is correlation between this method and other methods. So a study of 33 adult patients, 21 with cystic fibrosis, about half of which were insufficient, and then 12 healthy controls. And they compared both to MRI as well as to an endoscopic secretin test measuring bicarbonate. And what they showed was that there was similar correlation similar moderate correlation between fluid volume as assessed by fluid cross-sectional area as assessed by ultrasound and fluid volume by MRI, as there was between the fluid assessment by ultrasound and endoscopic pancreatic function testing. And so here we see the scatter plot of ultrasound cross-sectional area versus MRI fluid volume, and we see a relatively sort of moderate strength correlation between the two measures. So that's really the only, as I mentioned, direct measure of function that we can get by imaging. Some of these other characteristics that we can measure do require sort of a two-step dance, as I said, to get to estimates of function, or at least prediction of function, but we'll talk through these in turn. So parenchymal bulk was mentioned in the last talk. We see declines in parenchymal bulk in the context of parenchymal loss in chronic pancreatitis, for example, but you can also get it in patients post-surgical. And loss of parenchymal mass has been tied to both exocrine and endocrine function dysfunction, as was mentioned in that prior talk. So, this has been shown in the literature that the volume loss tied in with chronic pancreatitis has been linked to declines in function. Measurement of post-surgical remnant, pancreatic remnant, or prediction of remnant has been linked to expected function and to islet yield in patients undergoing pancreatectomy with islet cell autotransplant. And parenchymal bulk has also been linked to type 1 diabetes. And interestingly, they even see lower than normal volumes in the offspring of patients with type 1 diabetes, even before those offspring demonstrate any signs of having type 1 diabetes. Here are just a few of the papers that are out there in the literature, included in the slide set for your reference, but there are many more tying parenchymal bulk or parenchymal mass back to both exocrine and endocrine function. So how do we go about measuring parenchymal bulk or parenchymal mass? You can do it qualitatively. The difficulty with doing it qualitatively, in other words, me saying, oh, the pancreas looks small or there's subjectively atrophy here, is that the degree of agreement among radiologists is only fair to moderate. And so the reproducibility and repeatability of those assessments is not going to be great. So you can get at it in other sort of more quantitative ways. Couple of publications out there using parenchymal thickness. So in other words, anteroposterior dimension of the pancreas at multiple different segments. That can be achieved both by CT and by ultrasound, and normative values exist in the literature. Or we can get a little bit more fancy about it and truly segment the pancreas on our imaging on CT or MRI, not so much on ultrasound, but getting truly at parenchymal volume instead of thickness. And the advantage of looking at parenchymal volume is not all atrophy is created equal. Some patients lose mass in different parts of the pancreas unequally. And as many of you know, the shape of the pancreas is not necessarily uniform. Some patients have a larger tail at baseline or a spread out flat tail. And so by measuring parenchymal volume, you get more of a measure that can be more uniformly utilized across populations. The problem is this is labor intensive. It does at this point require manual segmentation. The work is going on to develop machine learning models that can automatically segment the pancreas with reasonably good results. That said, this is easier in adult populations than it is in the pediatric populations, because the adult populations have all of this nice visceral fat in the abdomen that helps the margins of the pancreas stand out, as opposed to a pediatric patient where things are more closely opposed. So we'll see how well we do with this, but progress is being made in automating these analyses. So I expect you will see this more and more going forward. So what about parenchymal quality? So how much pancreas you have isn't the only question at hand. You want to know how good the pancreas you have is as well. Calcifications are a meaningful finding of chronic pancreatitis, and one might think that they would give us some assessment of how good the pancreas is, though it's not entirely clear that that linkage has been made yet. So no great data yet linking calcifications to function, at least that I'm aware of. That said, if you are looking for calcifications, really the only ways to detect calcifications reliably are by CT and X-ray. MRI and ultrasound just aren't as sensitive as those other modalities yet. However, there are other things we can look at. We can look at signal intensity changes by MRI. We can look at fat fraction, as was mentioned in the prior talk, as a measure of the quality of the pancreas that the patient has. And then we can get at tissue stiffness, just like we do in the liver, trying to predict fibrosis. We can measure the stiffness in the pancreas using either ultrasound or MRI elastography as a measure or as a predictor potentially of fibrotic change in the pancreas. So talking about signal intensity changes by MRI as a measure of parenchymal quality, the two main sort of signal intensities that are studied in the literature are T1 weighted signal, where loss of T1 weighted signal has been linked to exocrine insufficiency and prediction of chronic pancreatitis, or diffusion weighted imaging, where what diffusion weighted imaging, which is shown at the bottom here, does is looks at how mobile water protons are within the tissue of interest. And as tissues become more fibrotic or more cellular, the mobility of those water protons is decreased, and you get what's called restricted diffusion. And restricted diffusion has been linked to exocrine insufficiency. So patients who have EPI tend to have restricted diffusion. Interestingly, the literature that's out there about diffusion and endocrine insufficiency, or at least in the context of type 1 diabetes, is that we see facilitated diffusion. So the water protons, for whatever reason, are a bit more mobile in type 1 diabetic patients than in normal patients. So still some work to be done. Here's an example of T1 weighted signal loss. Normally, the pancreas is the most T1 weighted hyperintense organ in the upper abdomen. You see the pancreas appearing bright here, brighter even than the liver. In the context of chronic pancreatitis or T1 weighted signal loss related to exocrine insufficiency, the pancreas becomes darker than the liver, and in some cases as dark or darker than the spleen. And that's what we're looking to try and quantify. You can do this semi-quantitatively by comparing the signal intensity in the spleen to another organ, or sorry, in the pancreas to another organ like the spleen or paraspinal muscle, and creating what's called a signal intensity ratio. Or you can do true T1 mapping, which actually gives true quantitation of the T1 signal. When you just measure on an MRI image like this, drawing a region of interest over the pancreas, that's a relative signal intensity, which is why you need to compare it to another organ. T1 mapping using specifically designed sequences actually truly lets us quantify the T1 signal in the pancreas. Signal intensity ratio, while only sort of semi-quantitative, has shown to have some predictive value. This was a study of 51 adult patients, all with chronic pancreatitis, about half of which had normal bicarbonate secretion, and the other half which had low bicarbonate secretion by an intraductal stimulation test. And what they found was that a signal intensity ratio of 1.2 had an area under a curve of about 0.9 to predict the presence of low bicarbonate secretion. And so what that's saying is a pancreas that is 20% or less brighter than the spleen suggests loss of enough signal to be linked with low bicarbonate secretion and exocrine insufficiency. These are examples of images showing true T1 mapping. The top is a normal patient with normal parenchymal bulk, nice bright T1 weighted signal. The bottom patient has significant atrophy and heterogeneous T1 weighted signal. These are the T1 maps here in the center. Mag those up. The normal patient here on the left, you can truly quantify the T1 weighted signal. It's right around 600, which is normal at this field strength. In this patient, markedly elevated at 1200 milliseconds, reflecting that T1 weighted signal loss that we see in the context of disease. Diffusion weighted MRI, as I mentioned, these are the data supporting that. 28 adult patients, about half with abnormal endoscopic pancreatic function tests, the other half with normal. And they showed that ADC values were significantly lower in the patients with exocrine pancreatic insufficiency. So in other words, we see restricted diffusion, decreased motion of water in patients with exocrine insufficiency, presumably on the basis of fibrosis in the pancreas. Finally, parenchymal perfusion. The data on this is more preliminary than about some of the other entities I was previously speaking about. But what is out there in the literature suggests that in the context of chronic pancreatitis and exocrine insufficient patients, there are measurable differences in pancreatic parenchymal perfusion. As I mentioned, you can quantify perfusion with MRI or with ultrasound. You can do it with CT, but it requires intravenous contrast material and multiple scans, so it's a relatively high radiation dose exam, and no one is really doing it. Here's one of the papers out there in the ultrasound literature. With ultrasound, we give microbubble contrast agents. You're probably seeing this in your practices to look at liver lesions, for example, and they're even doing it for what they call voiding urosonography, but this functions just like any other contrast agent. And in this study where they looked at patients with cystic fibrosis, what they showed is in the subset of patients who had exocrine pancreatic insufficiency, they had increased mean transit time, decreased blood flow, and decreased blood volume. So in other words, less blood flow, less blood volume in the pancreas, and the blood that was getting there was moving more slowly through the pancreas. Again, blood as enhanced by the contrast material. So all in all, decreased perfusion in the patients with EPI compared to the patients without EPI. Again, you can measure this with MRI as well with some more complex techniques, and you can do it without intravenous contrast in that context as well, but perhaps more easily measured at this point by ultrasound with ultrasound-based contrast agents. So in conclusion, there are multiple imaging modalities out there that we can use to predict or at least sort of postulate about the presence of exocrine or endocrine insufficiency, and in a few cases to truly quantify pancreatic function in the form of secreted fluid volumes. In general, MRI and ultrasound are better suited to the task of predicting or quantifying function, in part due to the increased soft tissue contrast and the multiple types of contrast you can get with MRI, as well as the fact that both of these are radiation-free modalities. The body of evidence for imaging to predict and truly measure both exocrine and endocrine function is rapidly growing and rapidly shifting. So I think there's a pretty bright future for collaboration in this space. So thanks for your attention, and I look forward to your questions.
Thank you, Andrew. That was really great for radiologists and non-radiologists. So I do have a question more to help us as providers. When we are collaborating with you and other radiologists, what should we know about when we're ordering the images and we're looking for signs of exocrine insufficiency, meaning not directly, for instance, secretory tests, but let's say we're looking for chronic pancreatitis findings. Would we order the imaging? A question that comes up a lot, with or without contrast, and also would we use secretin versus not? So two questions in one.
So the first major point I would make, we talked about parenchymal volume loss being linked to function. We talked about signal intensity changes on MRI. Even enhancement characteristics have been linked to function in a few cases. And the key caveat there is those measures are best assessed during a quiescent period. So if you have a patient with an attack of acute pancreatitis, that's not the best time to be looking for findings of chronic pancreatitis or findings that we might extrapolate out to function. We can sometimes see them in that context, certainly, but the swelling from the acute pancreatitis, the edema that's a manifestation of the acute pancreatitis can obscure some of these other findings and can interfere with some of these quantitative metrics. So the first thing I would beg of you is, certainly we're happy to image in the context of acute pancreatitis when appropriate, but if you're wanting to really get to the question of diagnosis of chronic pancreatitis or to prediction or estimation of pancreatic function, try to do that during a quiescent period. Mm-hmm. Now, with regard to the question about contrast material is contributory in terms of assessing how the pancreas enhances. Fibrosis that develops in the setting of chronic pancreatitis essentially causes the pancreas to enhance a little bit more slowly. So the contrast material can be helpful in that context. It also can be very helpful for assessing the peripancreatic vasculature. We're all well aware of the complications that can occur related to the vasculatures, both in the acute setting, but also the chronic thromboses and otherwise that we might see in more sort of chronic disease states. So at least at first imaging, it can be helpful to have contrast material. You may not need it with every follow-up exam. It very much depends on the clinical picture and what's going on. And then with regard to secretin, independent of using it as an estimate of secretory function, the contribution of secretin is in terms of increasing conspicuity of the pancreatic duct. Now, if the duct is ragingly abnormal and blown out, you may not need secretin, right? Because it's already sort of self-dilated for various different reasons. But you know, in a first-time presenting patient where you don't know what you're going to see, it can be helpful to have it there to increase the conspicuity of a duct that may not be severely dilated yet, or to increase the conspicuity of anatomic abnormalities like a divisum or an anomalous junction or something like that. So again, first-time imaging, it can be sort of helpful to throw the kitchen sink at the patients with IV contrast and secretin, and then from there sort of figure out what's useful in follow-up as you go forward.
Yeah, that's great. And you know, one of the questions that is on the chat is, after how long after the attack would you wait to assess for possible chronic pancreatitis so that you do not see the acute inflammation changes? I mean, you're welcome to comment on that, but we usually just try to wait a month, but sometimes even then you could see remnant, especially if the patient is known to have acute recurrent, but it's best if you could to wait a month. Do you feel, we came up with these clinical guidelines as pancreatologists, but I don't know that it was based on any evidence.
No, 4 to 6 weeks is reasonable to let the inflammation go down. I mean, obviously that's in more of just a typical interstitial edematous pancreatitis with peripancreatic edema. If you're dealing with a patient with necrosis and big fluid collections and all that sort of stuff, it's certainly going to take longer to resolve. And obviously we're going to want to double check the enzyme, levels before we do that scan, just to make sure a patient hasn't been percolating along with sort of repeat minor attacks and things like that. But as a general rule, yes, 4 to 6 weeks is a good amount of time to let things calm down a little bit.
Sounds good. Another question is on, is it a reliable test to get MRCP sequence along with an MR enterography at the same time?
Is that, yeah, so MRE in my world, sometimes people are referring to MR enterography as well as to MR elastography.
Yeah, that's why I did ask Dr. Gupta, and she did answer me, said enterography.
Okay.
Yes.
Okay. Yeah. So, with MR enterography, right, one of the things that you're wanting to do is to distend the bowel lumen, right? Because you want to have the bowel lumen filled with fluid so that you can really see the wall of the bowel and get a good assessment of wall thickness and enhancement characteristics. And so there is the theoretic concern that that fluid in the bowel will be distracting or create artifacts that make interpretation of the MRCP different. The other potential theoretic risk is, does it induce some degree of increased peristalsis and then creating motion artifact? We still use a bit of glucagon for our MR enterography exams, which deals with the peristalsis issue. So then really you're just dealing with a bunch of fluid in the bowel. And in the current era of 3D imaging with MRCP, you can generally get past that bowel signal and read those bile ducts through it. Very few of us read off of the MIP images, those maximum intensity images where they sort of turn the duct into a 3D model. We actually scroll through. The 3D models certainly do not look as pretty in the context of all that bowel fluid, but we can read those 2D images through it. And for a one-stop shop exam where you're looking for inflammatory bowel disease and either autoimmune pancreatitis or PSC or whatever you're looking for, I say do them together. Save the patient some time and some hassle.
Or maybe get a new in US, right, Patrick? For autoimmune pancreatitis.
Yeah, I would agree with you.
Yeah,
we certainly can help there, and just to tag on to the other question, same thing with sometimes when we're asked to look for chronic pancreatitis after a setting of acute pancreatitis, we also like to allow 4 to 6 weeks elapse before any US exam if we can.
Yeah, even for the EUS as well, if you want to look for chronic pancreatitis.
Yeah, because honestly, one of the major Rosemont criteria by EUS for chronic pancreatitis is lobularity. And indeed, one can see some parenchymal lobularity on EUS, even in just the recovery phase from acute pancreatitis, which may be transient. So we don't want to overcall that.
Yeah, no, that's a great point. Thank you. Well, we are kind of running out of time, but there's just a lot of exciting questions, and I see how some of them are very practical to patient care. So Rajan asked, is a GFR less than 30 or i.e. chronic kidney disease a contraindication for MRI with contrast?
Simple, quick answer, generally yes. Obviously, these are risk-benefit calculations and discussions. The new macrocyclic agents have very low or non-existent rates of nephrogenic systemic fibrosis, but if you can avoid it, it's certainly preferred, but that's where a conversation with your radiologist to figure out what the best method of imaging those patients might be would be in order.
Yeah, and maybe we'll just take one last question again for practicality. Are most radiologists trained for these evaluations when it comes to function testing? And apart from research center, are these assessments possible?
So the semi-quantitative measures, yes, Matos criteria, most radiologists are pretty familiar with that or can become easily familiar with that. The signal intensity ratios that I was talking about, where you just draw on the tail of the pancreas and on the spleen, pretty much anybody could do that as well. They don't take specific training. The true quantitation of fluid volumes does take some knowledge and skill, and at this point is operator dependent, though we are moving towards methods of trying to automate that. So that's a little less available. Contrast enhanced ultrasound becoming quite common in practice. So I would say most radiologists should be able to do that if you ask them to do that as a measure of perfusion. Diffusion weighted imaging is a simple MRI technique that we use routinely for other examinations. So that should be available as well. So long answer to your question, the vast majority of these techniques are going to be readily available, at least with just some discussion with your radiologist of, hey, I heard this can be helpful. Would you be willing to do it? And it should be straightforward.
That sounds, yes, very helpful information to know. Patrick, would you like to add anything to that or from the comments that were given on the chat?
I think I tried to respond to most of the questions, but if there are any more, I'm happy to.
Yeah, and really, if people have questions directly to any of our speakers or to me that I can help pass on, please do not hesitate to reach out. This was very, very informative. Thank you very much to both of our speakers, and thank you for all the audience for joining us tonight, and hope to see you next Thursday. Have a good night.
Thank you. Have a good night, everyone.
Bye.